Good morning to all. Today we are going to discuss about corticosteroids. So, coming to the point, what is corticosteroid? Okay, and we all know that the steroids they are produced mainly by our adrenal cortex. As coming to the anatomy of adrenal gland, we know that there is an outer covering that is adrenal cortex, and there is an inner portion that is adrenal medulla. The adrenal cortex is again divided into three regions, that is outermost zona glomerulosa, middle zona fasciculata, inner zona reticularis. And the zona glomerulosa will produce the steroid that is mineralocorticoid, and zona fasciculata produce glucocorticoids, and zona reticularis produce mainly androgens, that is male hormones. And we know there is an inner adrenal medulla, and this adrenal medulla will secrete various adrenal hormones such as adrenaline, noradrenaline, and dopamines, and they are collectively known as catecholamines. Okay, and these mineralocorticoids consist of aldosterone, and the function of aldosterone is to retain the sodium water in our body, and the glucocorticoids are involved in the production of hydrocortisone, and these corticosteroids are called as the adrenal cortex hormones because they are secreted by the adrenal cortex. Okay, so, coming to the pathophysiology behind the corticosteroid formation, this hypersecretion of this adrenocortical hormones will cause certain anomalies or certain abnormalities. They are Cone syndrome, secondary hyperaldosteronism, and Cushing syndrome. Whereas the hypersecretion of these adrenocortical hormones will cause a condition called Addison disease. And this Cone syndrome and secondary hyperaldosteronism is due to the hypersecretion of aldosterone, whereas the Cushing syndrome is due to the hypersecretion of cortisol. Here we can see the comparison between Addison's disease and Cushing syndrome. In case of patients who have Addison's disease, they suffers from serious or severe hypoglycemia. Due to this hypoglycemia condition, the patients become really weak and thin, and they have postural hypotension, gastric disturbances, general weakness, weight loss, etc. Whereas in Cushing syndrome, the patients they were all obese, and they have a severe hyperglycemia, that is excessive amount of glucose in their blood, and they have certain mental abnormalities, moon face, buffalo hump, fish mouth, etc. And in Cushing syndrome, the patients have a gynecomastia-like appearance, and they also have gastric disturbance as Addison's disease. And whereas in case of females, they will suffer from amenorrhea, that is absence of menstruation and hirsutism due to this Cushing syndrome. And this, all these patients, they have a thin skin, and purple striations are seen on their legs, etc. And also they have osteoporosis. Okay, next, coming to the classification of glucocorticoids, there are short-acting glucocorticoids, they are hydrocortisone or cortisol and cortisone. Coming to intermediate acting glucocorticoids, that they will act about 12 to 36 hours. They are prednisolone, methylprednisolone, and triamcinolone. Okay, next coming to long-acting glucocorticoids, that is their action will last for 36 to 72 hours. That is about 3 days they will act. And For the long-acting glucocorticoids, we have paramethasone, dexamethasone, and long-acting other beta-methasone or paramethasone agents. Okay, beclomethasone is also comes under the category of long-acting glucocorticoids. And coming to the classification of mineralocorticoids, we have three agents. They are aldosterone, fludrocortisone, and desoxycorticosterone. So, coming to the classification of steroids based on their potency, we have the drugs with equal glucocorticoid and mineralocorticoid activity. They are hydrocortisone. Whereas certain drugs which have a higher glucocorticoid activity compared to mineralocorticoid. They are prednisolone, methylprednisolone, and certain drugs which have only glucocorticoid activity. That is, they have no mineralocorticoid action. They are paramethasone, triamcinolone. Okay. And dexamethasone is the agent which shows highest glucocorticoid activity. Okay, coming to the mechanism of action behind the steroids will act through nuclear receptors. That is, the receptors they are found in the nucleus of the cell. And here we can see a cell. Inside the cell, we can see steroid receptors, and steroids will come from outermost portion of the cell, and it will enters into the cell and will bind to the steroid receptors. And this steroid receptor complex will further migrate into the nucleus, and they will bind to the DNA. And on DNA or genetic material, there will certain transcriptions, translation will take place, and ultimately it leads to the production of certain proteins. Okay, and the ultimate response is the either action enhancement of steroids or increased production of certain hormones or cellular response. Next, coming to the mechanism of action of glucocorticoids, as I already said, the steroid hormones enters the cell of target organ, and they binds to specific nuclear receptors, and the steroid receptor complex will form, and it will enter the nucleus. They binds to specific sites on the DNA and will regulate the protein synthesis and ultimately leads to a cellular response. So, coming to various actions of steroids, we have glucocorticoid actions and mineralocorticoid actions. Okay, coming to the glucocorticoid actions, there are certain metabolic effects, anti-inflammatory effects, immunosuppressant effects, and also other actions on our system. And coming to the mineralocorticoid actions, there are salt water retention is there. Okay, so coming to the glucocorticoid action, the first one is metabolic effect. That is carbohydrate metabolism, protein metabolism, and lipid metabolism. Coming to the carbohydrate metabolism, these glucocorticoids will increase the blood glucose level. By increasing the glycogen deposition in the liver, increasing the gluconeogenesis, reduce the peripheral utilization of glucose, and coming to the protein metabolism, they will cause an increase in the protein breakdown and thinning of skin, and will cause osteoporosis, muscle wasting, etc. Coming to the lipid metabolism, they increases the lipolysis, that is, increase the lipid breakdown. Whereas on long term, they will cause the redistribution of fat, that is, fat is mobilized from various extremities into the face, neck, shoulders, and will cause, or the patients will see a moon face or buffalo hump. Coming to their anti-inflammatory effect, they will inhibit the clinical manifestations of certain inflammations. They suppress the early phase of inflammatory reactions and also suppresses the late phase of inflammatory reactions. And they also have the capability to inhibit the production of prostaglandins and leukotrienes. and they induces the production of lipoproteins, and this lipoprotein will in turn inhibits the phospholipase A2. As we know that this phospholipase A2 is necessary for the conversion of membrane-bound phospholipids to arachidonic acid, and this arachidonic acid will act as the precursor for the production of various prostaglandins and leukotrienes. Okay, so coming to their anti-inflammatory action, as I earlier said, here we can see the lipocortin, which is inhibited by the glucocorticoids, and further COX pathway will get suppressed or arrested. Coming to the immunosuppressant effect, they suppresses mainly cell-mediated and humoral immunity, and also suppresses all types of hypersensitivity and allergic reactions. And coming to the other actions behind these glucocorticoids on calcium metabolism, it will reduces the absorption of calcium and in turn increases the excretion of calcium. So as a result of this condition, the patients may suffer from osteoporosis. And on GIT, they will increase the secretion of gastric acid and various pepsins. Okay, and will cause peptic ulcer. And on CVS, they causes increase in cardiac output and cause increase in blood pressure. Okay, so coming to the mineralocorticoid action, the glucocorticoids will have a big mineralocorticoid action also. That is the retention of sodium and water in the body. And also they have the capacity to promote the potassium excretion from the body. And they can cause edema and hypertension. As a result of this fluid water accumulation, the patients may suffer from severe edema and hypertension. Okay, so coming to the adverse effects, we have glaucoma is there, and limb muscle wasting is there, and the patients may suffer peptic ulcer, and the patients may show cataract or Cushing syndrome, and on CNS, they cause anxiety, mood changes, etc. And osteoporosis also a idea of glucocorticoids. And they also can cause hyperglycemia, hypertension, and dangerous HPA axis suppression. Okay. So coming to what is HPA axis suppression, as we all know that these glucocorticoids are secreted by our adrenal cortex. Okay, and this adrenal cortex will release this cortisol into the blood. Whereas this cortisol in blood, which has a negative feedback mechanism on our hypothalamus, that is excessive production of cortisol will inhibit the hypothalamus from stimulating the production of adrenal hormones. Okay, that is the exogenous administration of glucocorticoids will reduce the secretion of adrenocorticotropic hormones and corticotropin releasing hormone from the hypothalamus by a negative feedback mechanism. So, the endogenous glucocorticoid secretion as a result will get inhibited because our body may consider this exogenous glucocorticoid as the endogenous glucocorticoid. As a result, the normal production of adrenal hormones will get suppressed, and it will in turn leads to the atrophy of adrenal cortex. Okay, so the sudden withdrawal of this glucocorticoid therapy will precipitate acute or chronic adrenal insufficiency. So, in patients from the, if we suddenly withdraw corticosteroids from the patients may show withdrawal symptoms such as fever, muscle pain, arthritis, etc. And also may cause flaring up of certain underlying diseases. And this acute or chronic adrenal insufficiency may manifest as nausea, vomiting, abdominal pain, hypotension, hyponatremia, hyperkalemia, etc. So, in order to minimize the HPA axis suppression, we can use the steroids only if indicated. Topical use may preferred, and should prefer the patient lowest possible dose for a short duration of time. and administer the dose at morning time, and it will mimic the endogenous hormone levels in our body, and try alternate day therapy for chronic conditions. And the withdrawal of steroids after long-term therapy should be gradual. That is, should taper the dose gradually and then stop the medication. Okay. And here we can see various steroid preparations. They are available in oral form, parenteral form, topical form, inhalational form, nasal spray, and intra-articular form. Okay. And the hydrocortisone is considered as the chief natural glucocorticoid and should be given in emergency situations. And topical steroids are dexamethasone, betamethasone, and they can be given as creams, ointment, nasal spray, or eye drops to the patients. And we have inhalational steroids, they are beclomethasone, budesonide, fluticasone, etc. Coming to various uses of steroids, we have endocrinal uses, that is, they can be used for the treatment of acute or chronic adrenal insufficiency, and which occurs mainly due to the infection or sudden withdrawal of steroids. And it is precipitated by infection, trauma, stress. Okay, and the patients may suffer from vomiting, dehydration, hyponatremia, etc. And the management of this acute adrenal insufficiency